All right, now we'll move on to the updates that we provide from the three organizations that support CHoSEN. I'll start off with the data updates. We'll hear from Katie Breen, who is the Interim Executive Director of the Colorado Perinatal Care Quality Collaborative. And then we'll hear from Jade Woodard, who's the Executive Director of Illuminate Colorado. All right, this is a slide that's familiar to many of you. I love data, and without data, you're just another person with an opinion. I'd like to highlight Blair Weichel, as I always do. I embarrassed her. Where is she? Okay, I see all the pointing. Can we give a round of applause for Blair? She hounds you all for your data. She runs these beautiful run charts, returns them to you, in addition to thinking through what we could do better based upon the data that you all have entered and she has analyzed. So the data that I'm going to share with you reflects 1,654 substance-exposed newborns from CHoSEN QIC from 2017 to the present. Just want to pause and recognize that you all here, as well as those in your homes, have improved, impacted, touched the lives of over 1,600 substance-exposed newborns and their families. That is truly remarkable. Here we have some limited demographic information about the mothers and infants captured in our data set. On the left, you can see the quarter of birth with the number of opioid-exposed newborns or substance-exposed newborns that are captured. You can see that the numbers are quite variable. And that is not because there has been rapidly shifting changes in the number of substance-exposed newborns born in our state. That's really due to the hospitals that go in and out of our data system. Maternal ethnicity is shown on top. You can see that 61% of mothers are non-Hispanic, 29% are Hispanic, and we have about 10% missing, which I will note is a significant improvement from quarters past when missingness ranged anywhere from 25 to 30%. Below, you'll see maternal race. The majority are whites, with about 26% reporting as bi or multiracial. As you well know, we are not as racially diverse as other states, but we also know that it is crucial to capture data and report data by race and ethnicity. So as I mentioned, hospitals go in and out of our data system depending on bandwidth of hospitals, resources available, as well as the urgency to put CHoSEN QIC practices into place. So you can see that in 2017, when we first started, we had about 7 hospitals that were entering data. Our highest was at 2019, and then most recently in 2022, we have 9 hospitals still entering data. Now, this just highlights the hospitals putting data into the central data system, but we know that there are many more hospitals out there in Montana, Wyoming, and here in Colorado that are taking CHoSEN QIC resources and putting them into place at your birthing facilities. Here we have the percentage of mothers who are receiving any sort of medication opioid use treatments. Now, this is a very liberal definition of how we define medication-assisted treatment. In our data set, we capture this by asking, was there any record of use of methadone, buprenorphine, Suboxone? So you can imagine that there are limitations to that question. But that being said, we can see that there has not been a statistically significant change from our baseline mean of about 55%. And so I should backtrack and say, I don't want to use the word statistically incorrectly. Here, I don't really mean research. I mean using a quality improvement framework, meaning you need to have 5 data points that are different from your mean to say that you saw a significant change in your outcome. And here we do not have a period when we're seeing that change from our baseline mean. And so in short, we're saying we can hypothesize or conclude that the number of mothers in the prenatal period that are receiving treatment has not improved over time. Here we have our length of stay for all substance-exposed newborns. We exclude those infants that are less than 35 weeks or whose length of stay are affected by other diagnoses. So this is, no other conditions. It's really just substance exposure that potentially is keeping these infants in the hospital. We saw very significant declines early on from a baseline mean of about 13 days down to a low we had seen of 5 days in 2019, but that new mean of about 7 to 7.5 days has remained. And you can see that there were some signals during the COVID epidemic that our length of stay was going back up, but it is starting to come back down again. I do want to highlight, I was having a really interesting conversation with Camille from Parkview, and I'll first kind of sidestep and say Camille and those from Parkview and Memorial Hospital were really the early adopters of CHoSEN. The cohort numbers are astronomical in terms of what their group contributed. Early on, Parkview and Memorial, again, not a great statistic, but contributed over half of the data points to the CHoSEN QIC data set. But what she has been saying is that while Parkview and Memorial are not actively contributing data to CHoSEN QIC now, they recognize that their efforts are sustained, that sustainability is in fact taking place, but that they are seeing a lot of sicker babies and sicker mothers who are affected by substance use. And so what I realized literally just 10 minutes ago, that I'm not capturing those babies in this data set, because we're essentially looking at quote unquote healthy babies who are maybe late preterm or full term. So I think it's time that we do a deeper dive to better understand who are those sicker babies and mothers within our CHoSEN data system. So honestly, within 15 minutes, I've crossed overcome a barrier, crossed into another silo. So just another example. All right, and as I've mentioned, we need to stratify data by a number of characteristics, and certainly race ethnicity is a critical one. We know that there is no quality without equity. And therefore, we have stratified our data by Hispanic status, recognizing that the Hispanic group is our largest minoritized population in the CHoSEN data set. And so on the top, we have length of stay for substance-exposed newborns born to Hispanic mothers, and on the bottom to non-Hispanic mothers. And I'll direct your attention to the first half, the left side of this run chart, where we see that while both groups reach this new mean of a shortened length of stay, for the Hispanic group, it took a longer period of time, right? You see that slope for the non-Hispanic group being quite abrupt. There's a rapid decline. And for the Hispanic population, that decline took some time. Now, I'm happy to report that more recently, the lines are relatively parallel, that we're not seeing significant differences by ethnicity. But that being said, it's something that we really need to continue to follow. Here we see the percentage of opioid-exposed newborns who receive pharmacologic therapy. Early on, our peak was at about 61% with a mean of 54%. We reached a new mean of about 25% in 2018, and that mean has not changed. Again, during COVID, we started to see some signals where more of our infants were receiving pharmacologic treatment, and that has come down. Again, this data is stratified by Hispanic ethnicity status. On the top, we have the percentage of OENs born to Hispanic mothers who received pharm therapy compared to the non-Hispanic group. And again, that same trend where you're seeing rapid declines in the non-Hispanic group, eventually happens in the Hispanic group, but it takes a lot longer. And more recently, the sort of line continues to be relatively parallel without significant differences between the two, where the new mean is about 25% of our opioid-exposed newborns are receiving pharm therapy. Now, we know that if you receive pharm therapy, your length of stay is longer. And so here we have length of stay just for those infants that received pharm therapy. We had a mean early on of about 21 days, and then our new mean has been 17 days. And we haven't seen a significant change. Probably at the lowest, we had about a 9 to 10 day length of stay, and then more recently inching up. But again, we're looking for those 5 data points that are above that mean line. Now, this quarter 2 of 2022 of 50 days, I think we'll need a deeper dive. It looks like it was only 2 infants. And so we'll have to better understand if there were additional disposition, discharge, social issues that also necessitated a longer length of stay. Here we have the percentage of substance-exposed newborns that are eligible to receive mother's own milk. Eligibility is based upon maternal active engagement in treatment and no report of active use within the prior 2 weeks. and a few other criteria, which we'll talk a lot about later this afternoon. So this hasn't really changed. So we see that about 70% of our substance-exposed newborns are eligible to receive mother's own milk. Now, among those, who actually receive mother's own milk? And here again, we haven't seen a clinically significant change. So our baseline mean of 82% persists to this day. That being said, as I always say in these forums, Colorado is a breastfeeding state, and I think it's remarkable that even for this population, that these rates are very high. Colorado has the highest breastfeeding rate in the country, and I would conclude that I suspect for this population as well, one of the highest. Now, we know that hospital-based care is not enough for this population, and we have to think about transitions. What systems, referrals can we put into place at the time of discharge that optimize the likelihood for success? And we know that EI referral and assessment is a really important piece of that. And so at the time of discharge, we recommend, in fact, that all substance-exposed newborns have an EI referral in place. And so this is looking at that percentage over time. Our baseline mean was about 20%. We reached a new mean of about 35%. And then most recently, the new mean has gone in the wrong direction, downward at 31%. Now, while these new means are better than the baseline mean, it's still pretty abysmal. And so we're going to talk a lot today about early intervention, why it's an important service that is in place to support babies and families in this transition home. Now, we know that prenatal engagement is critical. Many of us take care of these babies, mothers, families during birth hospitalization because that's where we interface with that group, because there haven't been opportunities in the prenatal period, either due to lack of access to care and a whole host of other socioeconomic issues. And so while ideally we want to make sure prenatal consultations are in place, that is not the reality. So here we have the percentage of substance-exposed newborns whose mothers received some sort of antenatal counseling. We had a baseline mean of 4.5%. Our new mean, while improved, is still an abysmal 7%. Now, we recognize that this might be a documentation issue, that there may be conversations happening, consultations occurring, but we just can't find it in the electronic medical record. And so data capture absolutely is a huge piece of this, but I don't think that the majority of our mothers with substance use are in fact receiving anticipatory guidance. It may not be as low as 7%, but I still do not think that it's the majority. So again, today we're going to hear a lot about what prenatal engagement looks like, our Navigator program, and lots of exciting things that are taking place to address this. All right, so before we move on, any questions about the data? All right, fantastic. So now we'll hear from Katie Breen, who is the Interim Executive Director of the Colorado Perinatal Care Quality Collaborative.
Hello, good morning. So yes, hello, I'm Katie Breen. I'm the interim ED of CPCQC, which is the Colorado Perinatal Care Quality Collaborative. I won't read everything on this slide, but I know many of you know who we are, but for those who don't know who we are the state's organization that serves as the PQC, or the Perinatal Quality Collaborative. We also are the designated state for implementing AIM bundles in Colorado, so the Alliance for Innovation on Maternal Health. And in summary, we implement QI projects in NICUs and L&D units. We do a lot of other things that make us sort of the convener of maternal stakeholders across the state, but in my capacity today, I'll mostly be coming from the perspective of our work in quality improvement in hospitals in Colorado. So I wanted to talk about some programs that are related to CHoSEN that might be of interest to this group. So the first one is the Colorado AIM Substance Use Disorder Learning Collaborative, which is abbreviated to AIM SUD. It is a hospital L&D initiative that is focused on implementing the AIM patient safety bundle on substance use disorder. So the whole idea is universally screening on in L&Ds for substance use disorder, and then doing really comprehensive care and follow-up for those patients. So not just identifying patients with substance use disorder, but also making sure that they are counseled on recovery services, connected to recovery services if they are open to that, social work consults, all of those things. So we are now covering 46.9% of all Colorado births. Basically 46.9% of all Colorado births take place in hospitals that are participating in this collaborative. So as you may realize, it's very related to the CHoSEN work, because there's a maternal infant dyad and the substance exposed newborn. Their birth parent would be someone who would really benefit from the work that we are doing through AIM SUD. So I know many of you are probably from NICUs, but if your hospital L&D might be interested in getting involved to not just take care of the newborn, but really think about the birth parent as well in all of this, then definitely reach out to us, and we'd love to tell you more about it and see if you might be interested in getting your L&D involved. Second, another related program. So this right now is in Eagle, Summit, Pitkin, and Garfield counties on the Western Slope, but something we are hoping to scale beyond that region in coming years. And it's called Impact BH. And the whole point of it is establishing a perinatal behavioral health network that not only involves hospitals and prenatal and postpartum care, but also community organizations that provide services and address social determinants of health, address chronic stress, and really working with the entire community and developing a network to support birthing people and families, dealing not only with substance use disorder, but maternal mental health conditions and chronic stress in general. So that is something I'd be happy to talk to any of you about more if you're interested in learning more about that program. And then lastly, I want to talk about FIRST. So FIRST is our program called Family Integration to Restore Trust. As many of you know, for lots of historic reasons, many communities do not feel that they can trust the medical community for historical abuse, because of historical abuses. So what we do with FIRST is try to ensure that families are active members of the care team and collaborative partners in all of our work. And we essentially recruit folks with lived experience who are passionate about improving perinatal care and integrate them into the leadership of our quality improvement programs and of CPCQC in general. So we are recruiting right now for our second cohort of FIRST. So if you know any patient family members who might be interested in this work, they can become FIRST partners, and applications are open right now. And then I'll talk a little bit about recent funding that might be relevant to this group. First of all, just, I mentioned that we are the state's PQC. That's a designation from CDC, and we actually one of the states that CDC funds for this work. So we just ended a 5-year grant period with CDC and then started a new one about a month ago. So that's very exciting for us and shows really the faith that CDC has in the work that we're doing in Colorado. And then next, and this is what might be relevant to this group. So we just received, as a subrecipient of CDPHE, HRSA funding for state maternal health innovation and data capacity. And one of the things that that this grant will do is convene a maternal health task force across the state. And the point of that task force is to come together and work on basically a baseline needs assessment and then a strategy plan for how we will guide maternal health policy and improvement in the state for the next 5 years. So we are recruiting people to join that maternal health task force, and it can be providers, anyone in the clinical community, anyone in, the community at large, and patients and families are certainly critical to this work. But if any of you might be interested in being part of that task force and really helping us guide maternal health strategy in the state, you can reach out to us. The application is going to become live in the next couple of weeks, and happy to tell you more about that. And then lastly, and then I'll wrap up, we have a couple of exciting opportunities coming up. And there is a flyer in the swag bags outside actually about both this first. So there's a flyer about joining first in your swag bag, and then there will be this flyer also in your swag bag. So we were granted through the March of Dimes opportunities for training to, the training is called Breaking Through Bias in Maternity Care. It's about racial bias in maternity care, as well as just general bias in maternity care and how to overcome that as a provider. So there's a live training that I would definitely recommend. It's coming up on December 2nd. I'm sorry, this slide says Friday, December, but it's Friday, December 2nd, 9 a.m. to 12 p.m. And you can scan that first QR code. It's on the flyer, or you can go to cpcqc.org/events and you'll find it there. It's first come, first serve for 100 participants. Definitely recommend it to bedside caregivers, but really anyone who touches this work, anyone in this room, basically, it would be relevant to. So it's first come, first serve for up to 100 participants, but feel free to share it with your networks. And then second, the same training, but in a 90-minute version instead of 3 hours, is self-paced. You can do it online at your own pace. You can start and then stop and take a break and come back a couple days later. We also have 115 seats available for that training. It just has to be completed by January 30th. So again, feel free to share that with your networks as well. The flyer with all this information should be in the bags that are handed out at registration, or you can go to our events page, or feel free to come up to me and I will direct you there. But that is all from me. Yeah.
All right. Thanks so much, Katie. And I really do recommend that March of Dimes bias training. I have done it and it's fantastic. Next, we will have Jade Woodard, who is the Executive Director of Illuminate, Colorado.
Thank you, Dr. Hwang. Jade Woodard, Executive Director of Illuminate. Illuminate is a statewide nonprofit focused on strengthening families, organizations, and communities to prevent child maltreatment. And I am honored to co-chair Support Colorado, which you may have been familiar with hearing about as the CHoSEN Steering Committee. We went through a whole process in the last year to rename it. So Support Colorado stands for Supporting Perinatal Substance Use, Prevention, Recovery, and Treatment in Colorado. I am lucky to co-chair this committee with Dr. Catherine Wells, who I know you will hear from later this afternoon. And then Diane Smith is the chair of our Family Advisory Board as well, and you'll hear from her in just a little bit. So in the last couple of years, we have been working on these 4 priorities. So these were established through a joint steering committee and Family Advisory Board process in late 2020, early 2021, and has been our entire focus for the last 2 years. So we have made great progress through our Family Advisory Board Storytelling Project and our Provider Education Work Group on reducing stigma around accessing substance use disorder treatment and recovery supports. We've been working really closely in partnership with you all at CHoSEN, but also with our Plans of Safe Care Work Group and with the Navigator Program and some other things you'll hear about today on policies and practices with families that support really warm handoffs and standardized practices to address inequities. So a lot of that is embedded in the Plans of Safe Care work, and I think we still have a lot of room in that space to continue our growth in Colorado. In addition, we've been working on policy and data. We made recommendations around how to spend those opioid settlement funds that you heard the Attorney General speak about this morning, and have continued our focus and our partnership with our fetal alcohol spectrum disorder work group. If you have questions about any of the details of these priorities or any of the work that's been done, Kelly Sutton is the coordinator at Illuminate that is the point person and would love to talk to you about all things Support Colorado and how to get more involved. I'd like to specifically call your attention to the half sheet of paper that you picked up when you walked in that is our provider survey. And this survey was developed to assess what providers' education needs are, specifically in relation to the child welfare system. So as we heard Susan mention this morning, our tightropes across silos, one of the things when we first started doing this work was really around child welfare and medical providers, and how do we continue to build those bridges and strengthen those tightropes. And so we'd love to hear more from you all about what you're interested in learning about, And so there will be a gift card if you complete the survey, and then there will be focus groups to follow as we really look to build kind of what is the future of this work. And thank you to Dr. Halmo for leading it. And I know you'll hear more about that later as well. So there's your QR code. It's also on a half sheet of paper. Please don't skip it. So what's next? I mentioned we were kind of wrapping up 2 years worth of priorities. And so we are thrilled to be embarking on the process to establish what our new priorities are. If you have not engaged in Support Colorado, this is a perfect opportunity to do so. We need your input. We want to hear what's happening in the field, what you're seeing, where you'd like to see focus be moving forward. We do continue to anticipate this plans of safe care requirement. And I know you've heard from Dr. Wells and I about that several times, but we think that'll continue to be a part of it. There was recently some funding that the Kemp Center, Illuminate, and the Colorado Evaluation and Action Lab collaboratively have applied for and been awarded to do a pilot around plans of safe care implementation. So there is a lot of work that will move there, and we need your input to make sure that we have all the right priorities moving forward. So this is the timeline. We'll be really focusing on this between now and the end of the year, gathering needs and opportunities from our steering committee, from our family advisory board, from all of our work group members, having a handful of ad hoc meetings to really work through those different recommendations, and then come together as a steering committee and a family advisory board to finalize those priority areas in January. So please consider joining us and participating in making sure we have the right pathway forward. The last thing I wanted to share was just policy context. We are thankful to be close partners with you all in setting kind of some policy or strategy, and then also looking at what is being implemented. Over the course of the past couple of years, we have seen these 3 bills that have passed and are really specific to Colorado Medicaid and how Medicaid is implementing changes to how coverage specific, not necessarily specific to prenatal substance exposure, but in a way that will certainly support families that have been impacted by prenatal substance exposure, including extended Medicaid coverage. There is a really important flag here that right now the process is that patients must self-report to Health First Colorado, which is what we call our Medicaid program, or CHP Plus, the Child Health Plan Plus program, that they are or were recently pregnant in order to enact that extended Medicaid coverage. So the onus is on the pregnant person or the pregnant parent to be the one who is making that report to be able to have their coverage extend. The other 2 bills that are currently being implemented are focused on family planning. So one is the second bill on here was really focused on, regardless of, if someone might be higher than the income to get Medicaid coverage, they still could qualify for family planning services. And then the second one, or the third one on this list, is really removing the immigration status barrier to getting access to family planning services as well. So patients will not need a social security number and any of the things that they may have needed previously in order to get access to those services. So this is good progress we see in our state's Medicaid program, and there's so much more that we believe that we can all be doing together. And so we believe that policy will continue to be a big focus of Support Colorado into the future as well. So those are my updates. If you have questions or ideas, policy concepts, anything like that, please connect with Kelly. And we're really excited to be here in person together with you all day today.
All right, before we break for a break, any questions for the 3 organizations that you've just heard from? All right, well, we're gonna take our first break, 10 minutes long, and we'll return here at 10 to hear from Diane Smith, as well as Davida Schiff, who'll be joining us remotely from Boston. I ask one thing of you, well, one of many that will come today, but please today meet 3 people that you did not know before coming to this forum. And please try to understand their context, their organization, and opportunities for collaboration with those individuals. All right, see you in 10 minutes.